last presentation in this session by Dr. Chalapas, who's been a part of our team for many, many years, and he was instrumental in the success of many things we've done over the last 10 years. And he's going to tell us about PVL, paravalvular leaks in the mitral valve position, and where we stand today and how we treat them. Adonis.
Thank you for having me, Kostas. It's a really great honor to be part of the Congress. And in the next minutes, I'm going to discuss about the defects, the PVLs in place of mitral regurgitation, in place of the mitral valve. So what we know up to now, no conflicts of interest, and what we know is that opposed to the, do you see my slides?
Yes, we see them very well.
Okay, thank you. So opposed to aortic defects, the mitral PVLs are more common, 7 to 70%. They're larger and sometimes more complex in anatomy. They're more symptomatic, and in repair sometimes it's more difficult. Regarding the location, they're most frequently located anterolateral or posterior and posterior medial. And regarding the shape, we've seen that in most of the cases, 80 to 85% are oval or crescent in shape with irregular borders. There are several factors that contribute to the development, such as significant annular calcification, fibral annular tissue, infective endocarditis, or corticosteroids, and of course, there are several technical considerations having to do with sizing of the existing valve and the suture disruption of the existing valve. In most of the cases, the PVLs occur early, relatively early in the first year post-operation, in almost 75%, and the rest, 25%, occur lately, but in both cases, we have always to concern about the infective endocarditis. Clinically, most of them are asymptomatic with a relatively benign clinical course. However, up to 5% of the cases can lead to severe clinical consequences, such as congestive heart failure that occur in most of the cases due to volume overload. And we've seen that mainly with large leaks, or symptomatic hemolysis that occur in almost 40% of the cases. It is more often in mitral compared to aortic position. And lately, with the use of new generation valves, we've seen this complication less often. This is a very nice image coming from Garcia, showing the different mechanisms and hemodynamic patterns having to do with PVLs at the site of the mitral valve. And just to mention the fragmentation, the collision when there is the jet is suddenly decelerated in the left atrial appendix wall, or the acceleration when they pass through very small and short leaks. So it is very important in terms of survival to proceed with the treatment of these PVLs, and the best recommended approach, of course, is the surgery, and especially when the PVLs are combined with infective endocarditis, the association of instability of the mechanical prosthesis. However, the reoperation, it is usually associated with relevant morbidity and mortality, and they're often characterized by recurrency. That was the reason why the PVLs at the European guidelines at 2017 had the surgical approach as a class 1 indication, and they recommend the surgical approach, especially when there was combined with endocarditis or when there is hemolysis, and they gave at that time the 2B indication for the transcatheter approach, not because of its safety, but maybe because of the less experience at that time. Recently, the guidelines from the other side of the ocean, the American guidelines, upgrade this indication to 2A, and they recommend these procedures to be performed in centers of expertise when there are suitable anatomical features having to do with the size, having to do with the complexity, and having to do with the distance of the defect from the serum ring. Of course, there are several limitations to proceed with a percutaneous approach, such as the large defects when they involve more than 1/3 of the circumference of the prosthetic annulus. The stability of the prosthetic valve in stable working valves are a relative contraindication. Of course, there are several case reports in the literature where transcutaneously treated these unstable prosthetic valve defects, the presence of thrombus, and of course the active endocarditis. Regarding the diagnostic part, the gold standard is the echo, and especially the transesophageal echocardiography, which by the use of 3D analysis with color, the QLab analysis can give us very useful information in order to define the anatomy, the orientation, the shape, the size, and of course to evaluate the severity. However, we always have in mind the dropout phenomenon, which give us the impression of false anatomical defects. And when we want further to define the anatomy of these defects, we have to proceed with 3 ECG-gated computer tomography with 3D and 4D reconstruction, in which we can have information regarding the anatomy and, of course, the optimal crossing angles. Fusion techniques can be useful during the procedure, give us dynamic informations that can help us in order to proceed with a wire cannulation across the PVL. And these are the most common exercises, most commonly used the transeptal approach and the grade approach. We have to be very careful during the puncture of the septum. We have to go posterior and slightly superior so to have enough space for working inside the left atrium. When there are defects, especially posterior or septally oriented, then we can use as an alternative approach the transapical approach, which is direct and easy access, and sometimes we don't face resistance problems to cross the PVL. Of course, the transfemoral approach through aortic valve was used not so often anymore. It has the disadvantage of mechanical, electrical, and hemodynamical compromise due to compromise of the different devices with aortic valve, and it is mostly used for defects in place of the aortic valves. When we need a further support, then we extremely can use these loop techniques in order to increase our support during our procedure. And of course, imaging is very important with 3D transesophageal echocardiography, giving us information regarding the correct position of the defect, the correct function of the prosthetic valve during the implantation and after they release it, and of course the degree of the residual PVL. And of course, we can use different orthogonal fluoroscopic projections, either the right anterior oblique where we can see the mitral ring or the mitral device on each side, and it is very helpful during the implantation of the device, or the left anterior oblique in which we can see the mitral valve end phase, so we can easily confirm that our wires and devices pass through the defect and not through the valve. There are several devices being used to treat the PVLs. Most of them are the vascular block devices for nitinol, most of them round in shape with the exception of the AVP3, which is oval in shape, not used in USA, having only CE mark approved for the treatment of PVLs in Europe. In USA, they used most often the AVP2 and the Amblastad occluder. And just to mention that the VSD devices are very stiff and often worsen the hemolysis. The only up to now dedicated devices is the Occlutech, having CE marked since 2014 from nitinol, is a double disc device with 2 geometries, square and rectangular, with a secure mechanism and can be applied for both transapical and transfemoral approach. And in this configuration, we can see the most important parameters that we have to estimate in order to choose the correct device. So it is the size, if it is small or large, is the shape, if it is round or oval or crescent in shape, and of course the complexity. And we can see that in most of the cases, the AVP3 and the Occlutech rectangular device, it can be the more appropriate. And in case where we have large, complex defects interrupted by sutures or tissue creating small PVLs, we can use different techniques in order to apply more than one device, either at the same time, like the double wire technique, or subsequently, like the hopscotch technique. One issue during the procedure is the resistance and the friction to advance the sieve through the leak. And there are several techniques in order to overcome, like using a stiffer wire. If it is possible, smaller hydrophilic catheters to change the access site to a different point. And there are some cases reported in the literature showing that by using inflated fan guns, in the other side of the defect, and by the so-called pulling and pushing technique, we can overcome this problem. What important is also the several peri-procedural complications. According to the literature, are not so often seen. It is less than 5%. And just we have to point out the device interference with the prosthetic valve. This can be done either during the implantation, but sometimes we can see this interference after the release of the device that can change the device, the orientation, and then can obstruct the mechanical valve. And that can cause a hemodynamic compromise. So we have to be ready in order to remove, with the use of a snare, the implanted device. Of course, the embolization of the device implanted, it is reported less than 5% in most of the cases. And thromboembolic events, therefore, it's very important to have an ACT more than 300. And we have, of course, complications having to do with access sites. This is a very nice publication recently published in Eurointervention. Almost 200 cases, 70% having to do with defects in place of the mitral valve, where you can see that the large defects, more than 10 millimeters in maximum diameter, were less than 20%, and those who have a maximum diameter more than 50 were almost 5%. And regarding the complications, we can see that the defects in the aortic position are to treat the defects in the aortic position transcutaneously. It's a very safe procedure. The same is also true for the mitral, where we can see that the embolization, either early or late, it is less than 1%. And the more common complications seen having to do with access site complications and recurrency of the hemolytic anemia. Recurrency is often used when we don't seal these defects completely, and this is very important to try to complete to seal the defects complete. And in case of recurrency of hemolysis, due to residual PVL, there are different strategies. I think the one like wait and hoping that the epithelialization of the occlusion device is which we're going to diminish the shearing forces on red blood cells, and therefore it's going to decrease the hemolysis, could be one of our choice. In the literature, the first case reported for the closure of the defect in mitral position was 2003, 20 years ago. Since then, we have a small series regarding the defects in the mitral position. And we can see from this meta-analysis that in general, the technical and procedural success is very high, more than 80%, but it is less compared to aortic. This is a very nice study coming from recently from Spain, multi-center study showing that the procedural success in place of mitral lesion has to do with experience and, of course, with the device choice. And data coming from the Oquitec also revealed that the device procedural and clinical success is more than 85, almost 90% in most of the cases. Recently, we had published the Greek experience from different centers, almost 40 cases, 70% were defects in place of mitral position. And we see that the AVP3 was the most frequently used device, and the transseptal approach was the access site in 60 to 70% of the cases. Finally, data coming from Mayo Clinic showed that when we compare the surgical closure with transcatheter closure, there was not relevant difference in terms of short and long-term mortality. And they suggest that when we have a severe mitral paravalvular leak, symptomatic paravalvular leaks in place of mitral valve. When there is active endocarditis, then the choice must be the reduced surgery. In all other cases, we have to think always and first for the percutaneous treatment, and if that's not possible, then to proceed with the surgery. At the end, I'm going to close with an off-label use of these devices. In patients treated after mitral clip, we've seen often severe residual RMR, and we can proceed with closure gaps either between the clips or at the site of the clip by using the AVP2 in most of the cases with sufficient results. And in conclusion, I have to say that the transcatheter treatment of the PVLs in mitral position can be challenging, especially when the defects are complex and large. However, the success rate is very high. And with that, I want to thank you for your attention.
Thank you, Adonis. That was an excellent presentation and update on the transcatheter PVL closure. I hope that the TMVR transcatheter mitral valve replacement will have zero need for transcatheter closure in the future, thanks to the brave trialists like Roxana and Vinny we have today, and the brave trials they're going to organize and to prove them. And Adonis?
I was very, very surprised. Thank you very much, Antonis. Great presentation. I was very, very surprised to see that transeptal is the preferred choice even in Greece, because it seems to me that transapical is so much easier, but obviously it is more interventional choice. Would you like to comment on that, please?
Always we try to have a less invasive access. Most of these cases are cases of high surgical risk. So the trend is always to go from more to less invasive procedure. And I think the transectal approach, especially nowadays with the use of steerable catheters like Angelis, we can orient our devices even in medial and septally defects in place of mitral position, can give us this opportunity. So I think that according to the recently published data, we have always to try first transeptally, and if that's not possible, then we have to think about the transapical approach as an alternative approach.
There is no question that this technique has saved lots of surgical hours, during redos and so on, and has diminished a lot of the risk of redos. It is certainly very, very useful technique to have in our armamentarium. I think that probably we should develop better devices in order to be able to close better the shapes of the paravalvular leaks. I don't know your opinion about that. I mean, it seems to me that we have circular shapes, but really that the leaks are not circular.
I think that in very complex crescent in shape defects in mitral position, the use of the AVP3 or the Occlutech, the rectangular shaped Occlutech, could be a very good choice. However, when one device is not sufficient enough in order to close these defects, then by using more than one devices, either if they're round in shape, simultaneously or subsequently implanted, we can have a satisfactory result. And data coming from the Occlutech, recently published in the Eurointervention, the success rate was almost 90%. In the Occlutech is. So I think that, of course, this is an issue, but although there is a limitation of the devices we have or dedicated devices we have up to now, the results are very satisfactory. And I think that even in patients that were not only high risk, but also intermediate risk patients, we can think about this procedure as a first option.
Thank you. I don't know whether Vinny or Roxana has anything to add.
So I have a question, Dr. Chalapas. A great talk again. I was involved in a lot of these when I was in London with Shaq Qureshi going transapical in complex. Uh, I've learned recently that and been part of it that CT fusion, not fusion, but CT is also becoming important in pre-planning. Is that what you do as well, especially in complex leaks, where also in cases where there's a lot of mitral calcification in presence of a mitral valve already? CT has helped us a lot in getting the right projections to start with, so that when you're doing the case, it's just easier.
Yes, of course, the transesophageal echocardiography is very useful. However, for planning our procedure, in order to evaluate the anatomy and to see the orientation of the angles and the projections, they are going to use the CT, the ECG-gated CT. It is very useful for such information. So it is our part of our protocol always, such cases, to proceed always with a CT analysis of the defects.
Thank you.
Roxana, do you have anything?
Yeah, I wanted to. It was an exceptional talk, excellent. I had a little bit of a connection issue, but wanted to just ask you how, most of these patients, if you're using transesophageal, do you actually ever see that you will be going to ICE? How far along are we with ICE? Do you ever use it in these procedures? And do you see sort of a way that it could become more tolerable for the patient, not having to have general anesthesia, etc.?
A very nice question. I don't have any experience by using the ICE in treating these defects. Could be an option, I think, but I'm not sure about the artifacts that you can face by using the ICE during the procedure, especially with the mechanical valves. So,
Vinny, do you have any experience there? Or because I was seeing that there are now so much technology has improved in ICE. Now they're even doing some 3D, 4D ICE. So where do you see that in this arena?
I think Steve can probably answer it better. He's already raising his hand from Mainz.
We have Stefan with us from the next session. So Stefan.
Right, I've used ICE both in 2D and in 4D, both in vitro and also in vivo, and it works really, really nice. So especially if you can move either by a second transeptal puncture into the left atrium, or you go directly from the caval vein with a puncture on the other leg. You go directly next to even a 29 French device. You can go in the caval vein up to the right atrium. You use steerable sheaves like those from Occlutech or Oscor, and then you can get into any angulation on the annulus, on the valves, etc. It works really well. We have only done a couple of cases, but I have now 16 ICE catheters in stock at the moment, and we're starting the CE mark Siemens model first, and later this year we expect trials on the Philips system, which is a matrix ICE. So you get almost, in a smaller angle, you get almost TOE-like images from within the body. You don't have to intubate the patient anymore. So you can theoretically do mitral and tricuspid interventions, even replacement with local anesthesia. You don't need anesthesiology anymore.
Thank you very much. I think this concludes this roundtable because we have exceeded the time. So thank you very much all, and I hope we see you all next year.
Next year.
Thank you very much.
Take care. Thank you.
We expect you all in Athens next year. Thanks for being with us.
Thank you so much. Bye. See you all.